So, what we're going to talk about today summarizes sort of 4 points. Myocardial tissue characterization, how we can get at what's going on in the myocardium. Left ventricular function seems like bread and butter, but there's some new developments there. We'll touch upon them. Quantitative perfusion and assessment of coronary microvascular dysfunction. And then finally, let's call it broadly hemodynamics, or the diastolic dysfunction, your pulmonary hypertension, and your congestion. There's a number of new things going on there that we'll talk about. Starting off with the tissue characterization. So, bread and butter, late gadolinium enhancement to look at focal myocardial scarring. We have on the left-hand side ischemic scar that can be subendocardial or transmural, where the black represents the myocardium, the gray, the blood pool, the little thinner bit, the right ventricle. So we have a subendocardial scar, a transmural scar of ischemic origin. It respects a coronary perfusion territory. It emanates from the endocardium. And then we have non-ischemic patterns, which can be a whole bunch of things that basically don't respect coronary territories and don't emanate necessarily from the endocardium, at least not at the same time as respecting a coronary territory. It could be a number of cardiomyopathies, myocarditis, sarcoid, Anderson-Fabry, Chagas, and systemic sclerosis, amyloid. There's a whole bunch of things there. And but the key here is being able to say yes, no, lifelong ischemic medication. That's a huge commitment for anybody. Forget about the health system, about the individual and their pill box. But then, of course, if you have a very specific disease like Anderson-Fabry, you should be on some wholly other different medication. And we can get there a little bit with focal scarring, but there's more to the tissue characterization. But just a little bit of the prognostic value of late gadolinium enhancement. Here we have a large lateral wall subendocardial scar. In ischemic LG, presence versus absence portends a poorer prognosis. In non-ischemic LG, that's the case as well across a number of etiologies. Just one example, hypertrophic cardiomyopathy, presence or absence of LG the presence portends a poorer prognosis. So this is focal myocardial scarring. It's something that's happening in a specific spot. And we're going to contrast that to diffuse myocardial fibrosis, which we're going to get to. Now, I'd like to mention something about T1 mapping. It's a word that you might have heard. And the key word here is the mapping part. And mapping indicates in this setting that we're getting some quantitative information that we previously wouldn't have had. So all of these are images zoomed in on the left ventricle that are acquired using T1 weighted imaging. This is a little bit of a technical term, but you can appreciate that, for example, there's a higher signal intensity in the anterior wall than in the inferior wall. Even there's a gradient of signal within the blood pool. So there's no homogeneity of signal even within tissue that is of the same characteristics. And that's an inherent challenge in MR, is this variability. Basically, for the same reason that when you drive farther away from the radio station transmission, you have a poorer signal. And it's basically on a centimeter scale, loss of signal, radio frequency signal in the scanner. But we can do something to compensate for that. If we take 1 pixel in the myocardium, in the blood pool, and we plot its signal intensity versus how much time we've waited after manipulation of the signal. We won't go into the technical details, but there's a time here in milliseconds, 110 milliseconds through 5,270 milliseconds, or 5 seconds. The amount of time we wait will give us different signals. If you plot here on the bottom left-hand image, the blood pool, the vertical axis is signal intensity, horizontal axis that time, you can do a curve fit and solve for a time constant, which is called T1. And that is how we then create a T1 map. So that T1 map on the far right is each pixel in the image has had a curve fit for the signal intensity at various time points. And that now standardizes our unit of measurement to milliseconds as opposed to arbitrary signal intensity units. And you can compare between individuals, but also you have homogeneity within the same tissue. You see the blood pool is nice homogeneously of a given T1 and the myocardium of another one. You eliminate that heterogeneity of signal. So now we have a standardized unit of signal analogous roughly to the Hounsfield unit of CT. But there's important differences, but we have a similar standardization of signal. And that takes us from arbitrary units to quantitative units, which is really interesting, because now we can objectively see disturbances in T1 and T2, which is another property that can also be mapped. So here we have a T1 map, a T2 map by similar pixel fitting, and we did coronary occlusion and reperfusion in the dog. The microsphere is indicated here by poor flow. The TTC on the far right, the white, is the infarction. Infarction is smaller, the microsphere occluded territory is bigger, and in that microsphere occluded territory, we get objectively higher signal intensities in the T1 map and the T2 map. And this was a study that we did now a number of years ago, but sort of kicked off the field that now we have myocardial edema objective identification and a validation of that we can then use in patients. And the field moved forward and did that immediately then in myocarditis. Here we have the T2W stands for waiting images, and you can sort of see it's a little brighter in the lateral wall, but on the T1 map you can almost set a threshold that when it goes from green to red, that is when it's pathological. And then we look at the area under the curve on the right, and the largest area under the curve is the yellow curve, the T1 map, that has the greatest accuracy for detecting myocarditis. Just looking at that inflammatory response quantitatively in the myocardium. But then, let's take it to the next level. In the world of MR, we talk about T1, but we also are interested in 1 over T1. There's a reason for that, I'll get to it shortly, but we call 1 over T1 R1. Let's just accept for a moment that it's so important to talk about 1 over T1 that we give it its own letter, R1. And the reason that is that the change in 1 over T1, or the change in R1, call that delta R1, is linearly proportional to the concentration of a contrast agent. The change in R1, if we measure T1 before and after the administration of contrast, we get contrast agent concentration information. Now the contrast agent we use in MR clinically, the gadolinium-based contrast agents, they have a very well-known pharmacokinetic profile. They are small enough to pass across the vascular wall into the extracellular space of tissue, but at the same time large enough that they will not penetrate the cellular wall, cell membrane. Therefore, they're called extracellular contrast agents. They distribute in the body's extracellular space, both in the blood pool and then, of course, in the interstitium, but not in the cells. So that's interesting. If we can quantify the amount of contrast in the tissue and we know where it is, then we can draw conclusions quantitatively about, for example, the size of the extracellular space. And that's what we call extracellular volume mapping. This is the theory, and in practice, we acquire a T1 map before the administration of the gadolinium-based contrast agent, after, and then we do 1 over the pixel values, and this is all done on the fly in the background, automated. Subtract the pre from the post, we get that delta R1, and then we calibrate it to the blood hematocrit. The blood hematocrit being the fraction of tissue, fraction of the blood that is cells, 1 minus hematocrit being the fraction of blood that is not cells. And that's, if we know what that is, we can compare the relative contrast agent concentrations in the myocardium to the blood. At the end of the day, on the far right, we get a quantitative image, color-coded according to the fraction of tissue comprised of extracellular space. Now we have a physiologically intuitive unit of measurement in percent of tissue comprised of extracellular space. And of course, that becomes really interesting in the setting of a number of pathologies that disturb the myocardial extracellular space. So the first one and most interesting potentially is that of diffuse myocardial fibrosis. And there's been a number of histological validation studies in aortic stenosis where they took an opportunity during open heart surgery for valve repair to take a transmural myocardial biopsy with a thin needle, which can be done safely and routinely. And they compared, maybe we can just do it with just the T1, native T1, the T1 prior to giving any contrast. And then the horizontal axis here is the collagen volume fraction, stained with picoserious staining. Here we see the example on the left, a lot of red, 34%, 12%, 4% collagen volume fraction. So it's a little bit noisy with a native T1, but with extracellular volume on the right there, that's a pretty tight line. And it gets really interesting because of that. We can basically measure the extracellular space and the collagen volume fraction just using ECV imaging. So what kind of clinical implications does that have? Well, we went and did studies comparing native T1 without contrast compared to ECV with contrast and how that relates to survival free from death or hospitalization for heart failure. So here we see how the native T1s splay out in a dose-dependent manner with the highest native T1 values getting the poorest prognosis. But it displays out even more in that dose-dependent fashion with ECV. And if we look on the far right, the chi-square representing the strength of the prognostic association. In univariable assessment, it's much higher than native T1, and even in multivariable assessment in the green columns, the ECV is much higher than native T1. So this has taught us that ECV is the power number. Native T1 is important, but ECV is really where the money is at prognostically. But how about, is the tissue important in the setting of knowing the function? So we now can routinely do global longitudinal strain. You can do it by echo, do it by CMR. Here we put ECV and GLS head-to-head together. Turns out they're extremely weakly, I would say negligibly correlated. I believe the R squared of ECV versus GLS is something like 0.05. So 5% of GLS can be explained by ECV, so a negligibly small number. And it's incremental prognostically. So the top line, again, survival-free from hospitalization for heart failure over years of follow-up data we worked with out of Pittsburgh. The healthy GLS and the healthy ECV has excellent prognosis, and the double whammy of bad GLS and bad ECV on the bottom line gets the least prognosis. So there's an incremental value of the tissue characterization to the function of the tissue. Now here it gets interesting. You talked about ICD placement, and the established dogma is, let's look at SCAR, because SCAR is a potential arrhythmic loop. And our latest data, it's out in preprint, but not, and under review right now, is we shouldn't be measuring the SCAR. We should be measuring the rest of the myocardium and see how it's doing. Because if the rest of the myocardium is fibrotic with a diffuse myocardial fibrosis that cannot be seen by LGE, but only by ECV imaging, it portends freedom from ICD shock in here almost 200 patients. If you have an ECV less than 25, 0 shocks. And the higher your ECV in a dose-dependent fashion, the higher your likelihood of shock. I predict that this data, when it comes out and it filters out into the community, will potentially be a game changer for a paradigm shift in how we look at the susceptibility to arrhythmias. It's not about the focal scarring. It's about all the rest of the myocardium and its health or unhealth as determined with ECV imaging and not with LGE. So this is something that we've been really excited about, and think that it's going to be, it indicates it's important. We're ready now to do the prospective trials to put in ICD or not based on this instead of scarring, instead of the ejection fraction. Haven't gotten off the ground with it just yet, but that's the next step. So this combination of native T1 and ECV gives us a diagnostic space, of a diagnostic plane, if you will. On the vertical axis, we have the native T1 value with the millisecond value. In this case, it's at 1.5 Tesla. You can have it for 3 Teslas as well. And then on the horizontal axis, ECV, which is field strength independent. You have a normal range for both, but if you have distinct sort of crosshairs of combinations thereof. If you have only an increase in ECV, but not so much in T1, that's the kind of changes we see in diffuse fibrosis. The chronic infarction and scar gives us high ECV values focally without necessarily changing T1. But if you do have primarily a really high increase in T1 and not so much in ECV, that's what we see in edema and inflammation. Double whammy globally in amyloidosis, focally in acute infarction or acute necrosis of non-ischemic origin. And then we have the lower values. If you have a distinctly lower T1 value in the myocardium, we see that with glycosphingolipid deposition in Fabry disease and in iron deposition in iron overload cardiomyopathy. And then focally, both are low, both T1 and ECV in thrombus and in fat. So this has helped us greatly to do the quantitative tissue characterization to understand the clinical origin and the etiology of the changes we're seeing. So how about Minoka? This is the inpatient setting, and let me ask, do you get a quick Minoka scan?
We're trying to.
Well,
because, I mean, the big differential that everyone considers when you've got someone with Minoka is myocarditis.
Yeah.
And the only way of really determining that is with the use of CMR.
I will make the argument that there's more, but with the following data. We have two different studies that we did in Stockholm. I was involved in the latter of them. SMINC one was Stockholm myocardial infarction, normal coronaries. CMR on average 12 days after the admission for ST elevation and suspected MINOCA, as it's now called. And we saw the following distribution. So about 20% infarction, under 10% myocarditis, 20% Takotsubo, and the vast majority got normal. There were some others like hypertrophic cardiomyopathy and dilated cardiomyopathy that unusually get in there. But we redid the study, a new 150 patient cohort across all Stockholm, all comers with ST elevation, and we did it within 3 days instead. And what we saw was the amount of infarctions was still 20%, new cohort. But the myocarditis more than doubled. The Takotsubos almost doubled, and they were at the expense of normality. So the time course is really important to catch the pathology early. The inflammation and the regional wall motion abnormalities of Takotsubo and myocarditis are super important to catch early at 3 days and not wait out to 12. So it can be in your armor of arguing to get that earlier scan.
But there's a lot of echo.
Wait.
You can see big changes in TACO over a very short period of time.
Let me show you that data that we also have. Before we get, a normal echo is not enough. So here we have the distribution of echo findings in that same cohort. There was about, around 80% that had abnormal echoes, and they ended up being something. But among those with normal echo, those 23 out of the 33 with normal echo got a non-normal finding. They either went to myocardial infarction, myocarditis, or Takotsubo. 70% of normal echoes were abnormal when they went to CMR. So it's not enough to have a normal echo and say, we're done. Not only that, let's drill down into Takotsubos. We'll get to it here. The LV gram or the LV angiogram, depending on the terminology locally. If the LV angiogram showed Takotsubo, in 18 out of almost 50 patients, there was all kinds of other things going on. They had infarction, they had myocarditis, they had dilated cardiomyopathy, they were normal. The LV angiogram was not, if it said Takotsubo, it was not always right. And importantly, if the LV angiogram was normal, out of 60 patients, 10 of them had a Takotsubo out on CMR. The LV gram is a horrible tool at ruling in and ruling out Takotsubo, despite to the chagrin of our colleagues. When we did this blinded read, it's like they couldn't believe it. They're like, "Oh no," There's a lot of frustration. And then the echo in Takotsubo. Echo says Takotsubo, it mostly is Takotsubo. But when echo says no Takotsubo, it's missing. 20 out of 100, 20% is MR says Takotsubo when the echo misses it because of the challenges that we all know of visualizing all the wall motion regions and so forth. But if we go back to the previous slide there, CMR changes the diagnosis and management in Minoka. At the end of the day, there's just one number here at the top right there in 29% circled in yellow. New diagnosis that changes the management. 30% of patients in Minoka get a new diagnosis that changes management. They get said they thought it was an infarction, it was absolutely not. Or they thought it was absolutely not, but it actually was, and they had no idea about it. And that's a powerful number. You can ask yourself, what would you want your loved one to do, and when in the course of their treatment, to do a CMR or not in the setting of Minoka? I'll leave that as a rhetorical question. So that was myocardial tissue characterization. Let's take the step into LV function, which normally is our mainstay. We know LV function. It's a done deal, right? Well, before we get there, let's just do a little bit of reflection on the MR process. Here we have a Bond. He has the bad guy. He switches on the MR scanner, and the bad guy's gun and everything gets pulled away. And then the black guy tries to do a distraction. Bond turns off the scanner, regains his gun, and goes back to save the day. So that's how Hollywood looks at the MR scanner. And we know a little bit more than that. But let's just for a moment, just dial it back a little bit and have a little bit of a critical view.
What movie is that?
This was So I'm a little bit concerned. On the far right here, we have all kinds of measurement equipment, electronics inside the MR scanner room. That's a no-no. Now, if you were to turn on the scanner, where would the gun end up?
Not to the front of it.
It would go right into the bore. And just the concept of having an on and off button. The off button we do have, turns it off pretty much like that. But the on button takes a week? Yeah. It's measured in days and not seconds. Yeah. And then I am a little bit concerned about the ECG electrode placement. But there is some seriousness in the jest, and that is that we do have the MR safety issues. And it is a real thing, and so that's why it's so important to have adequately trained and protocolized ways of handling things. But also, it brings up the question a little bit of devices. Just to mention a little bit about devices, we're learning now, publications in the New England Journal, that legacy devices, almost everything, basically everything can be scanned. So we shouldn't be not scanning because we have something that we're concerned about, because it's really not really a problem. But we do find that when we scan, sometimes the artifacts are problematic. So a big device being an ICD in the left pocket will give problems most likely over the anterior wall. But if the question is to rule out infarction in the inferior wall, so it's dependent a little bit on, it's not a problem then. It's dependent upon the question. But there will be variations based on anatomy, the individual device type. But just because it's a device doesn't mean we can't do it. It's rather the opposite. And Scott's going to touch upon that a little bit later.
So why did it become such an issue?
It was hypothetical concerns. The data has not played out.
How many times have I had to argue with Hunter imaging?
Safety first. But Scott will touch upon that as we move on. But moving on to LV function, just a quick summary of our imaging modalities for LV function. There's a lot to go through in this slide, but let's just go on the far right to CMR. It is costly, but it's on the same cost order of magnitude as SPECT and PET. No radiation, no contrast necessary to get LV function, good temporal resolution. The availability is the challenge. The important thing is the accuracy and the precision, the repeatability. You get the same number each time with the lowest variability you want. And then you have some devices that will be in the problem, but it's not a huge problem, but it is something that we're weary of. But it's the precision that is the most important thing compared to the other modalities. We won't go into
operator variability.
And the operator, absolutely.
Some of those tests up there, I won't point out any.
Yes. And now we have at Hunter inline AI quantification that has superhuman performance with regards to repeatability. So it's really good stuff. Now, but let's talk about function. So we talk about GLS now in the echo world and in the MR world. So we did a study a couple years back. There's a strength of relationship, the R squared, the univariable R squared. GLS is related to all kinds of things. We have MAPSE, mitral annular plane systolic excursion, moving back and forth. EF, ESV, end systolic volume, endostolic volume, mass, left atrial volume. They're all related to GLS. So GLS is not some kind of independent, it's a composite measure of all these things. And that's perhaps why it performs so well prognostically, because it takes all these into account. But the question is GLS better than EF? And the answer is yes, GLS is better, global longitudinal strain. You can also do global longitudinal shortening. Better than EF. This is the strength of association with survival. But the killer is MAPSE. MAPSE puts them all to shame. MAPSE is our strongest LV function measure when measured as association with prognostic survival free from hospitalization for heart failure or death in a nice splaying, dose-dependent manner. MAPSE is the forgotten measure of LV function, and I would argue we should be measuring in every patient with CMR, which we do here at Hunter with the automatic inline superhuman AI automatic detection that doesn't require any work, just measures it each time. But we should be measuring it with echo. We knew how to measure an echo in 1986. 1988, we had normal values for different age groups. And we can measure with anatomical M mode. We don't need to even have done an M mode. We can just have the anatomical images. We can even take a little caliper, a linear caliper, just measure how much the AV plane moves. We have normal values for age and sex. And its agreement between echo and CMR MAPSE is spot on. It's the same number. It's not a different number. And importantly, in echo, sometimes the echo, only thing you can see almost is the AV plane. But that's all the thing you would need to see on the ICU patient or something like that. All you got to do is measure that MAPSE. And why is that the case? Probably, we're also learning, is because as the LV dilates, to get the same stroke volume, you need a lesser MAPSE. So it's an indirect measure of dilatation. As the left ventricle hypertrophies, you need less MAPSE to get the same stroke volume. So it all sort of ties together mechanistically and mechanically. The physics and the geometry of the LV are all represented in that number, and it plays out prognostically, which is something that I think we will see some change in the field. Yeah.
Hang on, so why are we using
We should be, is the answer.
We use it for diastolic.
This is systolic function. This is millimeters of AV plane.
We use velocity of we use EID prime as our way of determining filling pressures.
Yeah, but this isn't that. This is
I agree. I mean, this is a way of estimating longitudinal function. We would use GLS.
But it is the strongest prognostic measure. It beats the pants off of EF. It beats the pants off of GLS. You don't need any fancy schmancy. Just measure that millimeters. So I challenge you, and again, it's a little bit of a rhetorical challenge. Perhaps your next patient tomorrow, pull out that caliper and measure MAPSE and look at the normal values that are in the literature for doing it on a 2D image. You don't even have to acquire the M mode at the time of evidence.
I guess we kind of eyeball annual notion of the mitral valve as part of our overall assessment and reporting. You probably do. I know.
Yeah. Because I guess patients with infiltrated cardiomyopathies, longitudinal function is always depressed, and it's a really important kind of subjective measure.
When I see really low motion annuals, there's significant.
The prognostic data.
We don't tend to measure.
The prognostic data that I showed you was not in ambulance.
So why do we measure TAPSE but not MAPSE?
Well, I guess the theory is always that the RV contracts longitudinally much more than the LV. So longitudinal contraction, the longitudinal fibers in the LV are like, what, 20% of the fiber?
So the longitudinal fiber argument is bunk.
Yeah.
because there is no distinctly longitudinal fiber. It's all a continuum, and that's been shown also anatomically.
Yeah.
So, but that's what people say.
Yeah.
But hey, we can. I would argue.
Longitudinal function is often the first thing that goes in the LV.
Right.
Circumferential and radial contraction are often the ones that hang around.
And it's affected by the dilatation and the hypertrophy. So it has these associations with all the things. So MAPSE is the composite measure that probably performs better. Or no, not probably. It does. The data shows that it does perform better.
Is it a vendor thing? Like, do you get output taps
It's a sonographer thing.
Yeah. So ask your sonographer to please measure MAPSE.
Is there a correlation between TAPSE and MAPSE?
Well, that's a question. Let me ask: is there a correlation between LV and RV function? Some people, often, but not. It's not.
It all depends on the pathology.
It's
If
not.
they've got LV, if they've got hypertension, then it's going to be isolated RV.
Yeah.
Sure, yeah, but the whole plane moves together.
No. The free wall is very different.
You often see complete difference. If you've got someone with severe pulmonary hypertension, LV will look absolutely fine.
Oh yeah, we're not talking about someone who's got
MAPSE
severe RVs. We're talking about someone who's got a relatively normal RV.
Sometimes we see on CMR, I think that the LV can be very abnormal, but the RV.
Yeah.
Yeah.
Anyway, the data speaks for itself. Again, I'll leave that to you to ponder if that's something you want to do on your next patient or not. So that was about LV function. Now transitioning to quantitative myocardial perfusion and the assessment of coronary microvascular dysfunction. So we now have here at Hunter and in the MR world the ability to get quantitative images of myocardial perfusion at the time of imaging in color scale, where the unit of measurement on the far right is milliliters per minute per gram of tissue perfusion. And that's been validated against PET. Here we have on the horizontal axis myocardial perfusion PET, the vertical axis myocardial perfusion CMR, excellent correlation and blend element. But if we go back to the previous slide here, we have at health, at rest, we have about 1 mil per minute per gram, and then at stress, in a healthy individual, we get a very much high, in this case, a 6-fold increase in myocardial perfusion. It's excellently normal.
So you're doing this test?
We can do it.
So how do you stress it? What do you...
Adenosine.
Yeah, so this is adenosine stress in the scanner with an adenosine infusion.
You can't actually achieve that with treadmill exercise. You can.
Yeah, there's been studies, but
It's like pretty hard.
it's more reliable.
Coronary flow.
It's more. It takes about 30 seconds to get in the scanner in the in-scanner CMR compatible treadmills that you're running next to the scanner and throwing yourself down on the table again.
Is that a thing?
It's a thing, but it's not a big thing. It's a research tool.
It was a research.
But the big number has been finding focal perfusion abnormalities. So here we see a focal perfusion abnormality in the inferior wall, single vessel disease, RCA, stenosis. That's bread and butter. But on the far right, then we have coronary microvascular disease, where we have a augmented ability to increase that flow.
So that exists, does it?
Which one? Oh, it's huge. It's the only way. I mean, I hate to paraphrase politicians, but that we have known knowns, but it's an unknown unknown when we're not even measuring it. And so this microvascular disease is definitely an unknown unknown. Here we see a less than 2-fold ability to increase coronary perfusion quantitatively during stress, as in microvascular disease. So is that important? Well, let's talk about that and our thoughts about, we have on the one hand heart failure, we have coronary artery disease. There's a lot of obviously overlap in the ischemic cardiomyopathy. There's obviously distinctly non-ischemic cardiomyopathy and non-heart failure coronary disease. But we have these sort of 4 phenotypes that often are overlapping and interplay here. We have LVH, talked a little bit about that. We measure LV mass measurements by MR. The focal or diffuse myocardial fibrosis, we already talked about that. But then on the right-hand side, we get to coronary microvascular dysfunction with quantitative perfusion mapping, and then diastolic dysfunction. And often these are found almost concomitantly, all of them, in the patient with heart failure. But we're learning now with these new tools that we can, for the first time, see them. So what does CMD associate with? You'll be familiar with this, associated with diabetes, hypertension, obesity, CKD, female sex, age, other LV hypertrophies like HCM, amyloid, Fabry, aortic stenosis, and other non-ischemic cardiomyopathies. So there's a slew of things that lead to coronary microvascular dysfunction, and it's really prognostically important. Here's the global stress. So the average of all the segments of the LV at stress compared to rest. The stress myocardial blood flow less than 2 gives us a much poorer prognosis over time. This is data out of James Moon's lab in the UK, in London. And from that same lab, in collaboration with the Royal Free Hospital, also in London, global stress myocardial blood flow by CMR perfusion mapping. If it's above 2.25 mils per minute per gram, it's considered normal. If it's in a range of intermediate, somewhere between 2.25 and 1.82, that's microvascular disease. And then when it's below 1.8, that's obstructive triple vessel disease, when it's really globally severely reduced. It's a little bit frustrating that it's this little window here, but in practice, these cutoffs perform quite well and impressively. And so again, we have multimodal tools available. One can do a 2D echo of the Doppler of the LAD to look for coronary microvascular disease. One can do a CT perfusion scan. It's not quite there yet. SPECT quantitative perfusion, not really accurate. PET is also used and is very accurate, but CMR is a worthy competitor. The published data is shortly behind PET on using CMR perfusion mapping for assessing coronary microvascular
You haven't got
dysfunction.
what's the flow, fractional flow, what's it called, IMR, is it?
IMR, FFR, CFR, there's a lot of R's.
That's what I'll need.
This is just, regardless of method, how they determine coronary microvascular
Yeah, I
dysfunction.
mean, I always have an issue with them because they do this. Was it IMR?
IFR or IMR?
IFR is the latest.
Yeah. And that every one of the patients with microvascular disease have a normal IFR, right? So they don't have any, they can't, it's like a self-fulfilling prophecy, they don't have to put any normal people in. see if they've got anything wrong with them. And there's no controls in the group that they've all tested.
Yeah.
But everyone they think has got microvascular disease has a positive test.
Yeah.
Therefore, it's true.
Yeah. Then that's the advantage. We can put in purely healthy people in the CMR scanner, so we
Right,
can
exactly.
get that difference. And we've done that. We've shown, for example, males and females differ systematically. Females consistently have higher perfusion at rest, at stress, just the gender differences, or the sex differences, sorry, that we can see.
High
There.
perfusion.
Quantitative perfusion by CMR.
Really?
Yeah. And so we're looking into adding pressures to get a resistance measure, sex-specific cutoffs, and the field is emerging, but the broad brush strokes are there. We have a tool we can quantify. It's repeatable, it's precise, it's prognostic, it's diagnostic. So.
But
Yeah.
what about doing comparison against it?
Yeah, right now we're doing IMR versus stress perfusion. Right now, this data that we saw here was IMR determined that did microvascular dysfunctions. It's relatively small numbers, but the data is growing. Yeah. So that was the quantitative perfusion. Now, finally, to the hemodynamics. Now it gets into the world of maybe new information. We don't or not. We'll see. Diastolic dysfunction. We've developed and validated diastolic dysfunction grading by CMR. So here we have the E and the A wave by Doppler, and there's the E and the A wave by our new high temporal resolution CMR velocity measurement technique. Here we have the E prime wave by tissue Doppler. Here's the E prime wave by MR tissue Doppler equivalent, also with the high temporal measurement. Here we have the pulmonary arterial pressure by the TR gradient, and on the right there, the pulmonary pressure determined by vortex duration, and we're going to talk a little bit more detail about that coming up, but that's an excellently exquisite way of quantifying PA pressure. And then left atrial volume by biplane volumetrics, same thing by echo and by CMR. And when we do that head-to-head, we came out now a couple years ago, we get absolutely excellent agreement. Almost everyone is in this agreement phase. Here we have the echo classification of diastolic pressure. Here we have the CMR classification. There's only a few singular patients that are discordant. The Cohen's weighted kappa 0.87, excellent agreement between the methods. And this is, again, this high temporal resolution method. We call it SWIG, sector-wise golden angle imaging. We get 150 frames per second by CMR, velocity mapping, for the E prime and A prime, and the E and the A, this kind of in the same patient, and the agreement is very good head-to-head. So we do that routinely, but now let's talk about the PA pressure and this vortex duration that I mentioned before. What is a vortex? A vortex is a swirl. Vortex is concentric movement, or in a circular, the cyclone or the hurricane, depending on what hemisphere you're in, of flow. And here we see, this is the chest wall, so the chest wall here, and the back is on the left, so it's a sagittal view. And this is the flow coming from the RV across the pulmonic valve out in the main pulmonary artery. And this is a QRS complex, the start of the beat. At the far right is another QRS complex in a schematic. And this is each time frame. So we have 20 time frames of imaging. And we're looking at the flow in 3 spatial directions, time resolved. That's why it's called 4D flow. So it's 3 spatial directions plus time, 4-dimensional flow. And if we look here, we see this vortex that is very present there in the PA, in this image and in that image, but not in the final image. And if we count the number of time frames where a vortex is present, we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 out of 20. So the vortex duration time is expressed as percent of the RA interval. Vortex duration time here would be 50%. How does the data look versus cath? It's almost ridiculous. Vertical axis, vortex duration in percent, 50%. Mean PA pressure at cath, 42 millimeters of mercury. This is the first data that came out in 2008. I saw the graph and I said, that's ridiculous. That can't be true. It's too good to be true. The same group coming out of Graz in Austria, University of Graz, they redid it with another 100 patients. They got an R-square of 0.95. I still thought it was ridiculous, so we assigned a PhD student back in Stockholm to redo the study. And we did it with our own right heart cath, CMR vortex detection using their methods, and then we compared it head-to-head to echocardiography on the far right there. There's the area under the curve. CMR has an area under curve of 0.99 for detecting increased PA pressure, compared to TR velocities as 0.84, statistically significantly better. But it's just a ridiculously good method. It's an empirical phenomenon that you get these vortex formations, and how long they persist as a percent of the RR interval is just spot on with the mean PA pressure. And not only can we quantify the PA pressure, we also, as you may know, we can quantify cardiac output exquisitely precisely with MR. So now we're getting at pulmonary vascular resistance, the only missing link being the wedge pressure. Well, 2 papers out last year. One of them looked at wedge pressure estimated from CMR based on a formula using left atrial volume and left atrial mass. And the Bland-Altman plot isn't that great. It's like a funnel, and the standard deviation is 5 mils of mercury, which is not that helpful. But the other one uses the E velocity, transmitral E, and the average of the pulmonary vein S and D velocities. And there, I've rescaled it to give the same scale on both images. The standard deviation is 2.0 millimeters of mercury. Holy moly! Super accurate, non-invasive wedge. And it's using, again, prescribing the 4D flow over this is the 4-chamber view. You see the LV here, the RV here, the mitral valve, and it catches the 2 inferior pulmonary veins. And the difference to echo is where you measure. In echo, we have a tendency to put our sampling volume out into the vein. And across the mitral valve, we're at the tips of the mitral valve leaflets. But in the MR images, they specifically measured at the mitral annular junction and at the orifice of entry because they wanted to, from a theoretical perspective, get the pressure gradient at the orifice. And when you do that, basically it's E over outflow velocity over inflow velocity. This E over S and D. The E is the outflow velocity, pressure gradient between the LA and the LV. And the S and D is the inflow velocity, the pressure gradient between the veins and the LA. So it's the ratio of the outflow to inflow pressure gradients. And it just performs so incredibly well. And this is something that we're now exploring, the completely non-invasive CMR right heart cath. You get your PA pressure from the vortex duration, you get your wedge pressure from the E and the S and D waves, and you get your cardiac output by flow measurement that we do normally. And you have your complete right heart cath. It works only you need to be in sinus. So AFib is probably, the recordings take about 2 minutes each, free breathing, one for the PA, one for the LA, and a cardiac output on top of that. So maybe you're under 10 minutes for a non-contrast scan and free breathing scan to get these numbers. And so I think we're going to see a complete paradigm shift in who we cath and why, because we're going to be getting more and more data routinely in the clinical exam that's going to, oh my, I didn't know this patient had increased PA pressure and increased LA pressure because we hadn't been measuring it before. And so that has something that's blown me away. Then how does that translate to congestion in the lungs? If that increased LA pressure, does that give us congestion in the lungs? And that's what we're working on with Scott. These are singular sagittal slices out of a full 3D volume of, on the left-hand side, a control, on the right-hand side, a patient with heart failure. The color coding is the fraction of tissue comprised of water, the lung water density. So blue colors have low fraction, and there's a natural front to back gradient of higher, by gravity, higher values of water in the back. But of course, in the person with heart failure, it's just all high values. And on the right-hand side, the same paper compared normal lung water density that's below the upper limit of normal to wet lungs, and the wet lungs have a much poorer prognosis with regards to heart failure or hospitalization or death. And the interesting thing is, it's not everybody that has heart failure that has wet lungs. As we know clinically, not every heart failure patient is disturbed in their volume status. So we see here, healthy controls, they fit nice tightly under 21% lung water density. But if you're at risk for heart failure, some people tip over the edge. If you have a HFpEF in New York Heart 1 or 2 or 3 or 4, some more tip over the edge. If you have it HFrEF in New York Heart 1 or 2 or 3, 4, even more tip over the edge. But it's not like you're wiping out the normal values. So euvolemia can be seen as normal lung water density also on these maps. And so the work that Scott is doing is looking further to validate this with some more important methodological aspects, but also trying to develop a similar method by CT, which would be additionally very helpful to be able to do routinely because it's done so more often. So in summary, we talked about myocardial tissue characterization, focal scarring, differentiating between ischemic and non-ischemic origin, inflammation with T1 mapping, using T1 mapping to measure the extracellular volume fraction or the diffuse myocardial fibrosis, which is potentially and arguably the next paradigm shift in ICD placement decision making, replacing EF and focal scarring, but also characterizing the tissue to classify MINOCA and cardiomyopathy diagnosis with a combination of T1 and ECV. LV function, we can do GLS of course, but MAPSE beats the pants off of GLS, and MAPSE beats the pants off of EF for prognosis. Quantitative perfusion mapping, we can do it for ischemia diagnosis and for quantitative coronary microvascular dysfunction assessment. And then on the hemodynamics side, we can now classify diastolic dysfunction just as good as with echo. We can set the mPAP, the mean PA pressure, but in pulmonary hypertension. We can measure the congestion in the lungs and even get the pulmonary arterial wedge pressure non-invasively with an E divided by average of S and D. And if I were a politician and I saw this menu of alternatives, I'd be more than happy to pay to save money on that. Going back to the structural challenges we have in the Australian landscape, I think the solution is to just keep pounding away with the data and show the clinical utility, the diagnostic performance, the prognostic performance, the precision, and the utility in a day-to-day clinical basis. And I'm hopeful for that future, and hopefully we'll get there with some patience and some persistence. So we have a big team to thank back in Sydney. Scott is a postdoc within the group still, and we're continuing to work together. And also want to acknowledge our collaborators at a number of sites, both in Europe and North America, and in Singapore. And with that, thank you for your attention.